All right, OMPP, we have a full house. We have them all. You all ready?
Yeah.
Dr. Treadwell, are you ready?
Yes, I am.
All right. So just a couple of my reminders. We are recording this meeting. If you could please mute your line when you're not speaking, just so we can eliminate some of the background noise, that would be helpful. I will drive the agenda, but defer to Dr. Treadwell as we go through. We will do roll call voting. You can aye, nay, or abstain as we go through the vote. So just a reminder for that. And with the start of our agenda, we will have the call to order and remarks of the chair with Dr. Treadwell.
Good morning, everyone, and welcome. I want to call the meeting to order, and I have no remarks.
Thank you. Before I start with opening comments with OMPP, I wanted to mention to the board, you all received from OMPP a questionnaire on conflict of interest that was sent to our individuals that we were reviewing for the board and the therapeutics committee. If you have any questions or concerns related to what you received, please speak now and let us know. Otherwise, we'll just continue as previously voted, but just want to see if anybody had any questions, comments, or concerns on what was received from OMPP. All right, I am hearing none, so I will turn it over to Mr. Ross for opening comments from OMPP.
Good morning. We have no other comments for today. Thank you.
Okay, so that takes us then to the approval of the minutes of the last meeting.
Okay, I'll entertain a motion and a second for approving the minutes.
This is Carol.
Hart. Move to approve. Oh,
I'll
Hart second.
Whichever you need.
Okay, so we have a motion and a second. So I'll start the voting. Dr. Treadwell,
Aye.
Ms. Phippen,
Abstain.
and then Dr. Gupta.
Hi.
Dr. Hart,
Aye.
Dr. Marshall,
Abstain.
Dr. McCarty,
Aye.
Dr. Ott,
Aye.
and Dr. Williams.
Aye.
All right, so we have all ayes and 2 abstentions, so that motion will carry. Thank you. That then brings us into our update on PA stats. So for our PA stats in January, overall, we had 77% approved and 23% denied. We had just a little over 26,000 PAs that were approved and almost 7,500 PAs that were denied. So you might notice that that did increase, and that's related to our mental health products updates going in January. In the point of sale quick check, we had 82% approved and 18% denied. Of those that were denied, 23% went to the call center for further review, where 74% were approved and 26% were denied. And then on the manual PA side, we had 55% approved and 45% denied. And then looking at our, I feel like I skipped a line. No, I guess not. Okay, looking at our top 10 PAs for point of sale quick check. Stimulants were in the top. Not surprising, they usually are, but you may notice that they are even substantially higher than they normally are. And that's just because we had some of those edits of preference for preferred or non-preferred. Clonidine and guanfacine was in the second position, also with some additional edits on preferred and non-preferred for products, and then antipsychotics. So similar top 3 to what we've had, and then opiates in the 4th. But again, just some of that preference status change did increase the number of PAs that we saw go through there. And you might notice that the said benzos and SSRIs also increased from their normal kind of level that they're at. In the top 10 manual PAs, we had early refills, and then the GLP-1s, and then Wegovy and Zepbound. So similar to what we've had, but Wegovy and Zepbound PAs do continue to steadily climb. So we're continuing to kind of see continued increase of PAs for those products. Here's the graph of our trending overall. So you can see that fairly significant kind of jump up. The percentage overall of approval hasn't changed. It's staying about the same percent, but that jump in number of PAs that were requested in both the approvals and denials due to the changes in the mental health drugs is why we'll see that increase. I do expect like maybe even some continued increases over February and March. And then I think it'll eventually level out after we go through about a quarter to 6 months as people kind of fluctuate through what they have in PA already. So we'll kind of continue to see where our graph ends up as we go through. Any questions on that? I can say, I mean, we have obviously seen increased PAs, but we haven't necessarily had a riot happen, if you will, from prescribers. There hasn't been a huge outcry that we've seen, at least on the fee-for-service side. Managed care may feel differently. I'm not sure. They can certainly feel free to weigh in if they feel like they've had rioting in the streets, but I don't think we've had rioting in the streets with the things that we've moved. And because there's been a lot of continuation of therapy, I think that most individuals that were previously on therapy have been able to continue. Any questions on those before we move into opiates? All right. Opiates overall, we had total utilizers decrease just slightly from December, but our new utilizers did increase from December, which is actually not really surprising because we got past the holidays and then some folks probably had some elective surgeries, et cetera. So they got therapy as they had their surgery. And so we tend to see kind of new utilizers increase when we are looking outside of the holiday time. As far as our kiddos, they're hanging in at the average day supply of 4.6 days, so pretty similar to what we've seen. And then you can see the average MME group. Again, most of our people are in the less than 90, and we're continuing to work down in that 250 to 500 range. So we're starting to kind of dwindle away those people that are in that group as well. When we look at our graph of the above 90, here's the members that are not exempt today. So fairly steady with what we've had in the above 90 group and a very small population. And then here's our overall trending graph. And then as a reminder, the green color is the current utilizers that are adults. The cranberryish color is our new utilizers. And then the purpley blue color at the top is our kiddos. And so you can see that we're kind of continuing to have that like step down decrease a little bit, fairly steady with what December was. You can see again that cranberry color is a little bit bigger since we did have a little more new utilizers than we had in both November and December. But overall fairly steady and consistent with where we've been. Here's our less than 90 MME trending. So again, they've kind of been on a steady decline with maybe a little bit of leveling out in January. And then here's everybody above 90. And again, really what we would expect to see in this group. And again, such small number of members that there are just a few changes kind of makes the graphs look a little wild. Any questions or comments on those before we go into our RetroDUR proposal? All right, hearing none. So we are looking at or proposing to look at the use of blood glucose test strips and continuous glucose monitoring devices and the co-prescribing of both of those. And so as I'm sure most folks know that the American Diabetes Association standard of care recommend continuous glucose monitoring to be incorporated at the onset of diabetes anytime thereafter for children, adolescents, and adults whose diabetes are on insulin therapy, on non-insulin therapies that can cause hypoglycemia, or any diabetes treatment where the CGM may be helpful to their disease management. And we do allow CGMs in those individuals. They are beneficial regardless of age, sex, education, or income levels, or baseline diabetes characteristics. They measure interstitial glucose, which relates to the plasma glucose, but it can lag if you have somebody whose levels are rising and falling rapidly. And then people who wear CGM devices should be educated on potential interfering substances and other factors that may impact their accuracy. And so kind of this last point is there is situations where you would need to have regular test strips on somebody on a CGM so that they can validate their blood glucose, especially if they feel like their CGM isn't measuring accurately or if they have something that's interfering. That being said, that doesn't necessarily mean somebody should be testing their blood glucose with a test strip continually throughout the day with a CGM. The CGM should be accurate throughout. And so when we were looking at our data, we pulled data for folks that were on CGM devices from June 1st, 2025 through December 31st of 2025, and then also looked at our blood glucose test strip data from the same time frame. Or similar time frame, sorry, it is a month off. And so during the reporting period, there were 1,399 unique members that were identified as having a paid claim for a CGM. And then of those members, 430 of them, so about 31%, were prescribed concomitant CGM and blood glucose test strips, which is okay. We expect that. We do expect them to have some level of code prescribing. However, the thing that was a little off or maybe concerning is that the average quantity of test strips that were being filled by those individuals that were getting both was around 123 test strips per person, which with an average day supply of 36 days. So in general, that's giving them 3.3 test strips per person per day, which really should not be needed for somebody that's on a CGM. One of the things that have been noticed across benefits is that there are individuals on CGMs that continue to get high level of test strips, and then they turn around and sell those other test strips on things like Facebook Marketplace or eBay for additional income. So that is something that we're kind of evaluating. And so of the members, the 430 members that we identified, we have close to 200 members are exceeding 200 test strips over a 6-month review period. And really kind of what we would like to see is that nobody should be getting more than 200 test strips in a 6-month period. They really shouldn't need that. And so that's what we're kind of proposing, is to look at these individuals that are kind of continually receiving both supplies. So for the actual rule properties, we would be looking at all member ages and all genders, all prescriber types. There's not a defined diagnosis. We're really just looking to see who's getting blood glucose test strips that exceed a quantity of 200 test strips during a 6-month period, who are also receiving CGM devices, and whether it's the receiver, transmitter, or sensors during a 6-month time period as well. And then kind of the reverse if they receive a CGM device. So we're looking both ways. Again, no negating diagnoses, no negating drug therapy. And then our outcomes is to look at the quantity and day supply of blood glucose test strips will decrease while they're on the CGM device. So really, this is going to be an education to prescribers that they shouldn't need both. They should have some supply on hand so that they can validate what they're seeing in their CGM, but they shouldn't necessarily need to be testing continually every month. And if somebody is, then the prescribers really should be educating their patient on the appropriate way to use and what's happening with their CGM. Any questions or comments on that before I go through the newsletter topics?
Good morning. I do. Just from personal experience of taking care of my mom, her CGM often falls off. And so when you do try to get a refill, obviously it's too soon. So you do have to revert to using test strips until that prescription is time. You also can, call the manufacturer and try to get one sent to you. But I just want to put that out there that might be a reason why you may see people use more of the test strips, because the CGM is coming off.
I do know that we have allowance that if they do call the call center and say that they've had an issue with their CGM sensor coming off, that we have put in early refills for those. I'm looking at managed care to see if they do something similar. They're nodding. So I know we have allowance that I could see where potentially other insurers, maybe that's more challenging, but I do know if they would call, even if the member or the pharmacy would call for that, they would be allotted an early refill if necessary.
Okay, I wonder if the pharmacy knows they can call and do that, because a lot of times, I don't know. I know my experience in working in retail, they put that back on the patient to call the manufacturer and try to get it that way.
That's a good point, which was something we can include in the Dear Doctor letter and the newsletter, is that the prescribers they can call, or the pharmacy can call and say they've had an issue with the device falling off, and that they can get an early refill for that. So we could put that in the letters to have that notice out there.
Sounds good. Thank you.
Thank you. Any other comments or questions?
Yeah, this TR, I wanted to ask, if once a person's on continuous glucose monitoring, are they then on it for lifetime, or do you just, are there some patients that just get it short term for use if they're not on insulin? I agree with using it for patients on insulin, but do patients really need it if they're not on insulin?
Well, so it truly is those patients like, and I can go back up here so you can see it. So the guidelines recommend or standard of care recommend usually kids, right? Kiddos, children, adolescents,
Right.
those people that are on insulin. If somebody happens to be on therapy that causes extreme hypoglycemia, I know that's not very common anymore, but maybe they can't tolerate other therapies. So in those cases, they may need to be on that. Or if there's somebody that has a risk of hypoglycemia, you would have them on that. And if if their disease state management is difficult and you feel like they need a CGM, that's kind of what the guidelines recommend. So I'm not aware personally of anybody starting a CGM because they met that criteria and then only using it short term or falling off and going back to regular test strips, unless maybe they just didn't like it or didn't, it wasn't for them. So most people I would say that I am aware of, and I'm looking at like my other clinicians in the group to see if they're going to disagree with me, once they start a CGM, tend to continue a CGM pretty much lifelong, is my understanding.
Right. You're right. Nobody wants to prick their finger. Everybody wants the CGM. Even
Sure.
type 2s that are not on insulin. Everybody wants it. I get it every day. I want the CGM. But
Oh.
if a person's on a non-insulin therapy that's causing hypoglycemia, they need to stop it. I mean, that's really, in my opinion, mismanagement of somebody on diabetes. And there's only a couple of drugs that do that, and it's well known. And pretty much they shouldn't even be on that drug if that's doing that. There are many therapies that can prevent that. There are many other options, and you know for convenience, everybody wants a CGM, but I'm not sure they really need it unless they're on insulin.
And agree. So I think what I'm picking up now, what you're putting down, which is, are we overusing CGMs? And in reality, all of us have PA criteria on CGMs. Oh, we don't have PA criteria. Oh, sorry. I thought we did.
Yeah. The Indiana Medicaid program for diabetes supplies, we have arrangements with the manufacturers where we get the monitors, the meters, whatever, all for free, and the strips or the sensors at a very reduced cost. So that's a part of our PDSL program. So I understand your concern, but our current criteria do not require
We have
an insulin therapy for
Yeah.
folks to be able to go on
Well,
to our preferred agents.
well, I understand, but if you're not giving people, if you're not going to give people CGMs, that would definitely stop the strips and CGMs issue that you got. Because I agree with you. I think 200 strips is ridiculous. Maybe 100 strips on 6 months. I understand that some of these CGMs do not last the full 10 days, and you might need a periodic check in here and there, but it's very, and they do fall off, and I understand that, but once people go to CGMs, they're not really into sticking themselves very much anymore.
Right.
And I think if you really wanted to cut down on the use of both, you need to cut down on your use guidelines for the CGMs, to be honest with you.
Well, so what I think is this is our spoiler alert, is that we're doing this now as like a soft, like let us put some notice out there. And then eventually we will likely have PA that will limit the use of, like we have quantity limits on both today. We have quantity limits on strips. We have quantity limits on the
Right.
CGM sensors. But what it will turn into is if you're on a CGM, you're only going to be allowed this max quantity of strips per day or per a period of time. And that's probably the PA that will end up going in place in the future after we, send out these letters and kind of start moving some folks with some information. So we will, I think, to answer your question, we will get there. We will start to restrict and limit.
Right. Well, I think you need to really look at the CGM use. I just can't, a non-insulin therapy that causes hypoglycemia needs to be stopped, not given a CGM.
Yeah, the benefit of CGM in that case is actually it would be able to show the hypoglycemic events. So the member could go into the doctor's office and actually present them with the information that shows how they were going low.
Yeah,
For
but you
whatever
can
the
do
reason
that.
might
You
be.
can do that with strips too. You can do that.
I think that,
Yeah.
yeah, I think so Pooja's bringing up a good point that some people are asymptomatic, so you won't necessarily know, or they won't know to test. But I think that the bigger issue with the CGMs is for us to collect the supplemental rebates and the rebating in the way that we cannot have further PA restricting use on who it's used in.
Okay.
So the
Well,
cost
but then
benefit
you've
there.
just kind of contradicted yourself here to say that they would notice that they're in hypoglycemia. Well, how are they gonna they would notice they're in hypoglycemia if they don't notice, how are they gonna get a CGM to verify that they are in hypoglycemia?
Well, it does, so it's not specifying that. So what the guidelines say is if you're on one of these therapies that can cause hypoglycemia, then it is recommended to use a CGM, whether you've been hypoglycemic or not.
So what are your therapies? The sulfonylurea drugs? Is that what you're
Yes.
saying?
Yes. Like,
Oh my.
yes,
I totally
those
disagree
types
with
of
that.
therapies.
Okay. I disagree with that, but okay.
I mean, we do have patients that utilize that therapy, whether it's right or wrong, and I don't know what other therapies they potentially can or can't use or what their situations are, but there are people that are managed on that therapy.
And we've done retro to try to encourage patients away from those therapies.
Yes, yeah, you might recall we did a retrodur that was focused on, especially
Right.
those with CKD and cardiovascular disease to move to GLPs
Right.
and to move to SGLTs, but we only moved about 30% of folks, or maybe not even that
Right.
much. I feel like it was less than that.
Right.
Yeah.
Well, here's my concern. One, if doctors find out that patients can get a CGM on a sulfonylurea drug, I bet they start ordering them.
Anybody can get a CT.
Yeah, I mean, anybody can right now, so
I
I
know,
mean,
I know. But
theoretically,
that's what I'm
it's,
saying. That's not good. That's not good practice. To be putting people on sulfonylurea drugs. It's just not. I mean, it
So
helps
I-
some people, but if you're going to give them a CGM if they're on that drug, I bet a lot of people will start writing for them. All
So
right.
actually though, you bring up a good point, TR. We can actually look maybe at the number of folks that are on sulfonylureas and on these therapies. And see if there's something else that we could bring maybe in our next retrodur to this group, because your point is valid. And most people you think most doctors you think understand what the current recommendations are. And I just talked to a patient the other day whose doctor told them that as long as they kept their sugars at a level of about 200, they were fine. And he wasn't going to freak out about an LDL greater than 500 unless it keeps going. And like, what? So not every practicing physician is up to speed on things. So this is one way that we can start to ease them into that understanding. So thank you, though.
and truly, if you ever want to be surprised, go on Facebook Marketplace, go on Nextdoor. You will find a slew of test strips being sold amongst a whole host of other medical supplies. Yeah, it could get kind of wild.
Amanda, this is Beth. I think the best is the Walgreens by me that there's actually a sign out in the yard that says, "We'll buy test strips," and they provide a phone number.
Oh,
And you see it moved every once in a while, it disappears and then it comes back. So
nice.
it's like a little garage sale sign.
Love it.
Just because we have, the CGM kind of open, doesn't mean that we can't do things. So that for fee for service, that the 200 strip limit is a holdover from prior to CGM. And I can tell you that our managed care colleagues do not have that high of a limit currently. And so maybe from all this, we can kind of maybe come together on that too, so.
Any other questions, comments before I mention the newsletter topics?
I do. Just want to know what communication is going out to the members that are receiving both.
So nothing right now. It would go to the prescriber to let them know that they're receiving both. So that we'll have a letter that would go out, and then we'll also have the newsletter that would be posted publicly about the topic.
Okay.
We tend to not. Oh, go ahead.
Go ahead. I was going to say, if
Oh,
there really is a true concern with the Facebook marketplace and all of that, and I too have seen those signs, I believe there needs to be maybe some ramp up of communication to members that we know this is going on and what could be the consequences of continued practice.
I think it's the case. So we tend to not send member communications like that because we have a lot of difficulty with member address information, and people have moved, and then you have PHI going out and other folks are seeing it. And so we tend to try and stay away from member communication and more like educate the prescriber of like, hey, this is what's happening with your patient. We think you need to take a look at that and see what's going on. Not to say we don't ever do member communication, but we tend not to do like mass mailings, et cetera, like that for member communication just because of the risk. No,
I get that.
out.
I didn't know if something could be at the pharmacy level when they're picking up. That's what I'm getting at.
Yeah, so to your point, maybe it's a pharmacy notification of, hey, if you're dispensing both of these regularly, why? You as a pharmacist should know why.
Yeah.
And, maybe you should be, maybe it's more of like, from a pharmacy perspective, you may be subject to audit to understand why you're dispensing so many of both of these regularly to the same person. I mean, maybe that's the approach we take after the prescriber communication. Yeah, that's a fair point. All right, so the main article will focus on blood glucose test strips and continuous glucose monitoring devices and co-prescribing. So we'll talk about, both and what the recommended uses are for both, and then talk about the co-prescribing of them. And then secondary articles, we're looking at dose rounding of biologic and cytotoxic anti-cancer agents, and then what's new with pregabalin. Any questions or comments on the newsletter topics? So then next, assuming you guys approve both of these, then we will bring back the Dear Doctor letter and the newsletter at our next meeting.
Oh, quick question. So
Yes.
why just pregabalin?
And not adding like gabapentin?
Yeah.
Focusing on the studies of pregabalin with heart failure, they haven't included gabapentin.
Okay.
Any other questions?
Thank you.
Any other questions from folks on the phone? If not, if I could get a motion in a second for those.
This is Beth. I make a motion.
I'll second Beth.
All right, we have a motion and a second. Dr. Treadwell.
Aye.
Ms. Pippin.
Aye.
Dr. Gupta.
Aye.
Dr. Hurt.
Aye.
Did we lose Dr. Marshall?
We did. I mean, he's there, but
Dr. Marshall, did you join back yet? I think we lost Dr. Marshall momentarily. Either that or he just got angry with us and left. Dr. McCarty.
Aye.
Dr. Ott,
Aye.
Dr. Williams.
Aye.
All right, we'll say we have all ayes and one abstention there. And I know he wouldn't get that mad at us. All right. Next on the agenda then is updates from our managed care pharmacy. Any updates? Hearing nothing in the room. All right. That takes us then to new drugs. So we now have the Wegovy oral formulation. So we needed to add that to PA criteria, and you'll find that it's very similar to the PA criteria that's already there for the injectable formulation with a few couple notable differences. So we have the criteria around the diagnosis of cardiovascular disease in obese individuals who need risk reduction of major adverse cardiovascular events. And then similarly, age of 45 years and older, they have a BMI of greater than 27 kilograms per meter squared. They have to have one of the following, either a MI, stroke, or peripheral arterial disease. And then they also should be optimized on guideline-directed therapy, depending on their disease state, or that the prescriber has provided medical justification for use as to why they cannot be. And then they need to attest that they do not have type 1 or type 2 diabetes, that they will use it in combination with reduced calorie diet, increased physical activity, and that they will not use it with other semaglutide products or other GLP-1s. And then you might notice that indication of MASH is not in this grouping, and that is because it is not indicated for the oral formulation at this time. It's only the injectable formulation. So that is one notable difference. And this is the second notable difference, is that we are asking that they've submitted medical justification for use of the oral formulation over the injection. So we will be asking that they use the injectable before they use the oral product. There will be a dose quantity limit of 25 milligrams per day, and then a max of 1 tablet per day for each of the formulations that are available, the 1.5, 4, 9, and 25. For the reauthorization criteria, they will need to have history of use for 90 of the past 120 days. Again, the diagnosis of CVD, all the things that I just mentioned earlier, and that they're continuing to use therapy as we discussed earlier for the initial authorization. And then that they continue to have rationale for why they're using the oral formulation over the injectable, and again, the same dosing. Any questions on that before I go on to the next one? All right. We have a new product for immunoglobulin A nephropathy. So Voyxact, we are recommending adding to that PA criteria. They need to be 18 years of age or older, have a diagnosis of proteinuria associated with immunoglobulin A nephropathy confirmed by renal biopsy. The prescriber has submitted a baseline urine protein creatinine ratio based on a 24-hour urine collection and estimated glomerular filtration rate collected within the past 6 months. And then they need one of the following, so that they've had 90 days of drug therapy with an ACE or ARB agent at maximally tolerated doses, and that they've continued to demonstrate disease progression despite being on this therapy. So that's a proteinuria of greater than or equal to 0.5 grams per day. And they can obtain that 90 days after the ACE or ARB therapy initiation. And one of the reasons that we're looking at this, and you'll see we're updating it in the other group, is that there are a fair number of patients at 3 months, that about 30% that are treated with just ACE and ARB therapy alone that achieve remission. And then at 6 months, there's actually about 50% that achieve remission. So we're really looking to see if they can utilize some more cost-effective therapy first to achieve that remission. And then if not, then they can go on to one of these therapies or the other therapies that we'll talk about shortly. They need to have documentation supporting the proteinuria of 0.5 grams per day. You might remember it was at 1 previously, but there was updates to the guidelines. So we did make updates around that, and you'll see that in the other drugs as we come through. And that, or the prescriber submitted valid medical justification for use of Voyxact without historical use of an ACE or ARB agent. And then the prescriber is going to attest that the member will continue the concomitant ACE or ARB therapy while taking that therapy, or again, that they have justification for use as to why they cannot. And then the requested quantity does not exceed 400 milligrams every 4 weeks. And then the reauth, we have the requested agent for 84 days within the past 112 days. That they've submitted a urine protein creatinine ratio based on the urine collection demonstrating that they've reduced from baseline or that they're trending towards stabilization, and that the member is continuing their ACE or ARB, or that they have valid justification for why they cannot, and again, the same dosing. And then in our new drugs, Jascade is a phosphodiesterase inhibitor, but not for COPD. So we would like to rename the PA to phosphodiesterase inhibitors for pulmonary related disorders so that we can include Jascade within that PA criteria. So Jascade is for the diagnosis of idiopathic pulmonary fibrosis. It needs to be confirmed by lung biopsy or high resolution computed tomography demonstrating usual interstitial pneumonia or probable UIP-HRCT pattern, and or a diagnosis of progressive pulmonary fibrosis confirmed by consistent decline in lung function. And then the member should be 18 years of age or older, should have a forced vital capacity greater than or equal to 45% of predicted at baseline. And then member has a carbon monoxide diffusing capacity greater than or equal to 25% of predicted, should be prescribed by in consultation with a pulmonologist, and then the requested dose does not exceed 18 milligrams twice daily. And then their reauthorization is just looking for history of the drug therapy, 90 in the past 120, and that they've demonstrated a positive response to therapy. And the requested dose, again, at 18 milligrams twice daily. Any questions, comments on new drugs today?
I do have one about the Wegovy. Typically, injectables are more expensive than the oral. And I think I read that the oral is going to be a prior auth to make sure that they have tried the injectable. Can you explain that?
Yeah, so when you normally think that the orals are cheaper than the injectables, in this case, that is the exact opposite. It is more than double, in fact, the cost of the injectables for some of what we look at. So it's quite more costly. And actually, it doesn't happen very often, but we also see it like in the anti-migraine space. So you'll have the CGRPs that are injectable tend to be far more cost effective than some of the oral agents. So yeah. And Ribelsis too in the GLPs, so which they're, renaming. Yeah, but,
Okay.
but similar situation is also more costly than the injectables. Yeah.
Okay, thank you.
Any other questions?
Yeah, this is Dr. Marshall. I'm sorry, my laptop blew up. I guess it was telling me to quit talking. Is this, so I just got back on and it's probably going to blow up again. It looks like it's ready to die, but did you talk about Zepbound here or is that later?
No, we did not talk about Zepbound. Zepbound criteria is not changing. It's just the new oral Wegovy formulation that is available that we are adding criteria to.
Are we talking about that later in this one, in the guidelines that you sent out? Zepbound?
We're talking about Mounjaro, the diabetes formulation.
Okay, all right, but we're not going to talk about Zepbound today. Because I have a question on the PA that you sent out on that. So should I bring that up in new business?
Yes.
Okay.
Yeah, we'll get to new business. Let's hope your computer doesn't explode before.
Yeah,
then.
that's my concern because I definitely have a concern on on prior authorization on that.
Okay.
All right.
Well, any other questions or comments on new drugs? If not, we can do a motion in a second.
This is Carol. This is Carol. I can move to approve.
This is Kelly. I'll second.
All right, I have a motion and a second. Dr. Treadwell.
Aye.
Ms. Pippin.
Aye.
Dr. Gupta.
Aye.
Dr. Hart. I'm not hearing you, Dr. Hart. Did you say aye? Can Dr. Hart hear us? I don't. Can you hear us, Dr. Hart?
I can't hear you.
Called here. I say aye.
Oh, I hear that. We heard that. Okay, aye, perfect.
Yeah, sorry, my speakers are cutting out.
No worries. Dr. Marshall,
Aye.
Dr. McCarthy,
Aye.
Dr. Ott,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Any liaison with other boards? Discussion today. All right, hearing none. Any old business today we need to go through? I'm also hearing none, so we will go on to new business then. So Dr. Marshall, when we get to the GLPs, I will pause and let you add in
Okay.
your feedback for that.
Okay.
So Debut, they came out with a sticks formulation, which is like a powder packet. The only thing we can figure is they came out with it because this is supposed to add flexibility for taste and amount that you're taking. So I'm guessing the oral solution does not taste very pretty, but that's just my assumption based on what they say with the powder packet. So that may or may not be true. But so the Debut oral solution is at the 120 mils per day or 8 bottles per 30 days, and then adding in the Debut sticks. So the 5,000 and 6,000 milligram packets will be at 4 packets per day or 120 packets per 30 days. And then the 8,000 milligram packet will be at 2 packets per day or 60 packets per 30 days. All right, for the GLP-1 PA, we are looking at updating for all agents. So there is currently criteria around getting a baseline hemoglobin A1C and then demonstrating reduction in that baseline. We are adding to the PA that the submitted hemoglobin A1C demonstrates a reduction or trend towards stabilization over the past year versus trying to look at the original baseline, because we've had some prescribers with issues getting the original baseline, and that's caused some issues. So trying to look at, is it stabilizing or trending even over the past year when they prescribed it initially for the reauthorization criteria. If there is not a reduction in baseline, we are looking at justification for use. So if there's a reason why it didn't stabilize or reduce over baseline, or even over the past year, it hasn't reduced or stabilized, is there a reason why, and the continued use for that product. So that's what we're adding into that. And I think do we have something else on Mounjaro? Yeah. And then on Mounjaro specifically, and this is for the diabetic formulation. So just trying to make, I know they're the same drug, but they have their different indications based on their trade name. So for Mounjaro, updating the age limit to 10 years of age and older, and then updating criteria regarding trial and failure of a preferred agent to include some additional verbiage. So right now it's previous trial and failure of 2 different preferred GLP-1 agents. At least one of these must either be Ozempic or Trulicity. We are adding as applicable based on the FDA approved age limit. So if somebody is in that 10-year range, the other products don't have that indication. And so in those patients, they would not need to trial a preferred agent because it's not indicated for their age. And then dosing is if they're 18 years of age and older, it should not exceed 15 milligrams per week. And if they're less than 18 years of age, then it should not exceed 10 milligrams per week. So I'm going to pause there and let Dr. Marshall add in his feedback.
Oh, well, I'm good with Mounjaro. It's the Zepbound that I'm the problem with, but I didn't realize you have to try Ozempic or Trulicity first, so that's good to know. So I'm good with that if you want to go to Zepbound criteria.
Well, we're not discussing Zepbound specifically, so I'm just pausing now.
okay.
If you have something to add on
All right.
Zepbound.
Well, it got the prior auth got sent out on the notes that I got, or the email. But anyway, my concern is on Zepbound, you're asking for documentation of a sleep study within the past year. And I would say that a lot of sleep studies have been done 2 or 3 years ago. And I don't know why we would have to repeat another sleep study to get the Zepbound use. I think that's an added cost to do another sleep study within the past year. So I would like to see that be removed. I thought we discussed that prior when we were talking about that.
So we did. We have that in there, or they have continued use of their CPAP BiPAP, because then they don't need a sleep study because it's not
Oh.
going to be accurate. So it's basically sleep study, or you have continued use of your CPAP BiPAP in the like continuous use.
Study from past.
And you have a sleep study in the past. Like, so you could have had a
Okay.
sleep study 10 years ago. And as long as you're using your CPAP BiPAP regularly, you don't have to have another sleep study. But
Okay.
if you're not using a CPAP BiPAP and you had a sleep study 10 years ago,
Uh-huh.
we are asking that you bring one that's more recent so that we're
Okay.
validating that you still have that. Does that make
Okay.
sense?
Yeah, well, it does, but or's not in there. It just says one of the following.
Yeah, well,
Uh,
yeah, but that implies either this one or
Okay.
that one. Yeah.
I would tell you, you would have people, that's the big problem with primary care is that they have no way to download these documents. And a lot of people with sleep apnea are not seeing their sleep doctors, but they tell their primary care they're using their CPAP. And that's going to be a problem for out in the state, I see. If they primary care can't document the downloads, that's a problem.
We haven't
Okay.
experienced it as a problem yet on the PA. Like of people not being able to get it. I'm looking at, I want to see what the actual criteria is. But documented adherence, are we making them send in the actual like sleep form, or is it the prescriber attestation enough?
Because I would tell you,
But it can be in their chart note, right? Yeah, so
Well-
you can put in your chart note. I think we discussed this too. So if you don't download it, that's fine. If you want to put in your chart note, patient is compliant with CPAP BiPAP, that's enough. Now,
Okay.
I know you
right.
may be taking the word of the patient, right? The patient
Right.
may come to you and say, I'm
Right.
compliant.
Oh, yeah,
That's-
well, I don't want to tick off the doctor. I'm going to tell him I'm compliant. Yeah.
I mean, that's what, I mean, that's
Yeah.
at some level,
Okay.
like we have to draw the line somewhere, I guess. So we're trying to make it accommodating to prescribers to where they don't have to have a download of the sleep, like the form. If they want to, they can, but they don't have to. They can just document in the chart. Even if you want to say patient states compliant, so it's not like you're assuming,
Okay.
you could just say they're stating
But,
they're compliant.
okay,
That's
all right.
acceptable.
Well, then I'm going to tell you this. There are people that have mild sleep apnea that are on CPAP, okay? And Zepbound is only covered for moderate to severe. So if you're going to give it to people who are on CPAP, there could be
They-
people that are mild, that have mild.
But we still have that original sleep study, remember? So if that original sleep study 10 years ago said that it was mild, then they're not going to get approved unless they have a sleep study that says it was moderate to severe at some point.
Okay, all right. Let's see. I don't see where that, okay, diagnosis of moderate to severe, but you don't say in here that, okay.
They
the
have
only
to
thi-
provide their AHI value, like in the, of the sleep study of 15 or greater. So no matter what, if the sleep study was in the past year, 20 years ago, whatever, it still
Okay,
needs to have the
okay.
AHI that's showing moderate to severe.
Okay,
Otherwise,
so
if
you're,
they were
okay,
mild, they
so
wouldn't
that's a number 2. Okay,
Mhm.
all right. Greater than 15 is, okay, all right. Okay, but see in that first one, because I'm going to tell you how this came up. One of my, when I told her that Zepbound was covered for sleep apnea, the people said, yes, but you have to get a sleep study in the past year to prove that they have sleep apnea and it's moderate to severe. So I think people are reading this that they got to do a sleep study in the last year. It's kind of confusing. Here. The wording of this is definitely confusing. I guess one of the following, I would put maybe an or after the first bullet, because that's what came up, because when I was talking about it, these people said, oh no, but you got to have a sleep study in the last year.
We can do that, or maybe we'll highlight, like we could even highlight the one or something so people understand that it's, but we'll take a look at that.
Why don't you say, instead of having a prior AHI greater than 15 events, put have had a prior sleep study showing moderate or severe sleep apnea. That might be and then if you want to put parentheses greater AHI greater than 15 in parentheses, that might be a little more easy for people to understand, because this is a little confusing. I can see that. I was even a little confused when I read it, or people are not getting to the second one and bullet and reading it. So I think an or in there. Or I would take out the greater than 15 and put moderate, severe, then parentheses, AHI greater than or equal to 15.
Yeah, we'll take that back and we'll mock up some wording for OMPP to review, and then
and I would love to look at that, but yeah, that's what my people told me. I said, "Oh no, you can get it for a moderate severe, but you got to have a sleep study in the past year."
Yeah,
So,
I mean, if they are not on if they have to have a sleep study at some point and be on CPAP, BiPAP, or sleep study in the past year, and not be on CPAP, BiPAP.
They're not reading the second bullet's the problem. It's and I missed it too. I think I put an or in there.
Okay.
And then I would just say moderate or severe, because you basically say this up at the top, diagnose of moderate to severe, and then you change it down here saying greater than 15. And some people that are working this don't really know AHIs, but they can read on the bottom there, moderate to severe. So I would kind of keep the language the same. You went from moderate to severe, and then you put greater than an AHI. So I think that would be less confusing. All right.
We will look at that.
Okay.
Thank you for that.
All right, great. Thanks. And my computer didn't blow up this time, so I guess I shut up in time.
Well, that's good. I'm glad.
All right.
Any other questions or comments on GLPs before we move on to the updates on all the IgA nephropathy? All right, perfect. So I had mentioned earlier that we were updating all the IgA nephropathy agents PA. So for the Filspari, Tarpeyo, and Van Raffia, I mentioned on the proteinuria cutoff, the new guidelines look at greater than or equal to 0.5 grams per day. So we did update that it's across the board. We're updating it for all the agents. And then for Filspari and Van Raffia, the baseline submission of urine protein creatinine ratio based on 24-hour urine collection and estimated GFR. Filspari and Tarpeyo updating the verbiage regarding the trial of ACE and ARB to state the use must be at maximally tolerated doses. And then with demonstrating continued disease progression as we defined earlier. And then Tarpeyo and Van Raffia updating verbiage to include attestation that the member will continue ACE and ARB therapy while they're on therapy or have medical justification why they can't. And then Van Raffia updating the verbiage regarding trial of Filspari to state member must demonstrate continued disease progression even though they're on Filspari for 90 days. And then I'm updating the reauth criteria similar to the other about collecting the urine protein creatinine ratio. And demonstrating reduction from baseline or trend towards stabilization. So again, just unifying the criteria so it's similar across the other agents within this group. And then some non-SUPDL agents, PA and step therapy updates. So Espruzio, removing from PA as the medication is CMS termed and no longer manufactured. And then for the Ciclos tablet, removing the reauthorization criteria and updating the PA for the member must be under 12 years of age or 12 years of age and older. And one of the following, that they're unable to swallow the capsule formulation or that they have submitted medical justification for use. The reason we are updating this one, as well as Xromi, next to it is there used to be additional dosing formulations available of hydroxyurea in capsule formulation. While they are still available, they are not participating in the Medicaid drug rebate program, and so we cannot reimburse for them. And so now there is only a 500 milligram strength available. That does not allow for dosing flexibility for a lot of patients that need additional dosing flexibility. So we wanted to update the solution and formulations so that they have that members under 12 years of age or 12 years of age and older and unable to swallow the capsule or having additional justification so that they can access that criteria or access that agent outside of that and have it be a little bit easier. We would also like you to consider, even though this is not an SUPDL agent, OMPP would like you to consider asking, well, I say asking or requiring, mandating, however you want to look at it, that the managed care entities also follow this criteria, which I believe most of them are already in agreement for anyway, so that's not an issue. But they want to have this as something that they also follow and align with so that we make sure that everybody is having access to the product across the board. Any questions on that?
Yes, hi, I have a question. My name is Lisana Sanchez. I'm one of the pediatric sickle cell doctors at Innovative Hematology. Thanks for bringing this up.
I'm sorry. So the questions are only for the board. We have to have, sorry, only people from public comment or public that register for public comment are able to speak during the public comment session. My apologies.
Thank you.
Hey, Amanda, it's Beth. I would just ask the
Yeah.
MCs, as far as I would assume there's not an issue with this for you guys, right?
They were giving a nod, yes. So.
That
Perfect.
they're in agreement, that there's not an issue, not a nod that there's an issue, a nod that they're in agreement with alignment.
Okay, perfect. Thanks.
Okay. In the OTC drug formulary, the capsaicin 0.075 cream, removing it from coverage, that will start on 5/1 of 26. And then in our preferred brand updates that will also be on 5/1/26, additions to the drug list include Besavance ophthalmic suspension, Teflaro injection, and Xylet ophthalmic suspension. And then removals will be the Daytrana patches. They're discontinued, so they can no longer be on the list. And then some SUPDL updates for the beta adrenergic and corticosteroids, Trelegy Ellipta maintaining its non-preferred status and updating the step therapy for the asthma indication to say that they must have trialed and failed a beta adrenergic corticosteroid combination inhaler for at least 90 days of the past 120. We did previously specify some inhalers that then were forcing people that had previously been on a different inhaler to go through that, even though they were all preferred. So we're just kind of encompassing all inhalers, if you will, before they get to that. And then on the macrolides, the erythromycin capsule removing from the SUPDL because it's no longer available. And the erythromycin tablets moving to preferred status. It was previously non-preferred, so kind of moving them over since the capsule is no longer available. And then a vaccine edit, this is informational only. The COVID-19 vaccines, the next spike, updating minimum coverage age at VFC pharmacies to 19 years of age or older in the VFC pharmacies, and the non-VFC pharmacies maintaining 19 years of age or older. That is all of new business. Any questions, comments, concerns from the board on new business? If not, if I could get a motion in a second, and not to, like, you can say if you don't want to do this, but I'm going to assume this motion in a second is going to include alignment of the MCs with the hydroxyurea as we discussed, unless you do not want them to align, and then you can say that in your motion in a second.
This is Beth. I make a motion that we accept the new business recommendations.
This is Peter. I will second.
All right, we have a motion and a second. And also to add that we will take, in this motion and second, we will take back the GLP criteria and add those verbiage for, as Dr. Marshall discussed, and give that to OMPP. All right. I will do the vote. Dr. Treadwell.
Aye.
Ms. Pippin.
Aye.
Dr. Gupta.
Aye.
Dr. Hart.
Aye.
Dr. Marshall.
Aye.
Dr. McCarty.
Aye.
Dr. Ott.
Aye.
And Dr. Williams. Dr. Williams, are you there?
In the chat, it said she stepped away.
Oh, okay. So we'll call her abstain for the moment. All right. Perfect. So we have all ayes and one abstention. So that motion will carry. We will now go into our public comments. Let me grab my handy clock here really quick. Yes. We did that at the beginning. They had no comments or further comments. They were fine. Oh. Okay. All right. So first up, we have Stacy Rapatsky for debut. Stacy?
Good morning. Hello,
Morning.
can you hear me? Hi.
I can.
Okay, thank you. Acadia appreciates the addition of debut sticks to the existing debut prior auth, and I give my time back. Thank you very much.
Thank you. Do you know, does the solution taste icky? Just out of curiosity.
For some patients it does. And
Okay.
actually, that is one of the reasons that the new formulation was created, that in addition to volume, that can be an issue, and storage requirements sometimes.
Awesome. Well, thank you. I just wanted to confirm my potential thoughts, so appreciate it.
You were right on.
All righty. All right. Thank you for that. Next up, then we have Dr. McFadden for Voice Act.
Good morning. Can you hear me okay?
Yes, we can.
Thank you so much. Now, provided the pre-A criteria recommendation from the board for Voice Act, I am happy to yield my time back this morning as well.
All right. Sounds good. Okay.
Thank you, though.
All right. I believe then that takes us up to our last agenda item, Dr. Treadwell, which is adjournment.
Okay. We're adjourned.
Thanks, everybody. Have a great
Thank
weekend.
you.
Bye.
Thanks.
It's a good It's lady and friend with dates, ladies. I didn't get a response. Like, those other places must have high.
I don't think it's putting it on that list, or you said.
Oh, no.